inshallah, I look forward to a great day زي امبارح. I think yesterday was excellent. I'm sorry I'm talking in Arabic. I don't know why I'm doing this. Very natural, sorry. Yesterday was an amazing day. I think it was extremely important to lay the foundation for the work that we're doing together, the work on the National Clinical Guidelines. Of course, we all agree how great an endeavor it is, and we're very grateful to our colleagues from the regional office and headquarters for their contribution, and we look forward to a very good plan together. For this plan to materialize, we had to start with laying the groundwork, laying the foundational groundwork for on which we are building on our next steps. So in the next few minutes, I will just wrap up some of the sort of a briefing for what was happening yesterday. And I'll also share with you the plan for today. So basically the plan is quite similar to what you have in your agenda with a few minor changes. So I'll go through those. But let me try to brief you on just a recap of things that we went through yesterday. So we started with Dr. Arash, who went to the very, very basics of defining what a guideline is. So what a guideline is, so that we're all on the same page, and that basically guidelines are statements that include recommendations intended to optimize patient care, informed by a systematic review of evidence. They then discussed what is about WHO guidelines in particular. There was a focus on WHO guidelines, and the emphasis on the recommendations and how recommendations should be explicit, transparent, should be performed by a multidisciplinary team, and then we talked about why guidelines are important. Although this is stating the obvious, but I think Dr. Mohammed Fawzi mentioned them, Dr. Arash mentioned this, and again, it's always important to remind ourselves of why we are doing what we are doing. Guidelines, of course, are important for many reasons, including improving the frequency of appropriate care, reducing unnecessary care, reducing variations in healthcare, improving process and patient outcomes, cost containment, focusing on research in adequate areas of research. Dr. Mohammed Fawzi then gave us a briefing on the plan that the General Organization for Teaching Hospitals and Institutions is working on. And Dr. Mohammed described the mandate by His Excellency the Minister of Health that was given to him to lead the role on development of national clinical guidelines. This is important that we have a unified format in the country, and this is where the process started. He described this mandate and why guidelines are important in Egypt. He talked about the vision of GOTI and then the mission, which involves unifying Egyptian guidelines and rapid adaptation and preparation for universal health insurance. And he put several lines under rapid adaptation. So this is an issue that was raised several times, that in Egypt there is a pressing urgency for us to move as quickly as possible. Dr. Mohammed then shared a 10-step roadmap, which I have personally become familiar with, and Dr. Mehrnas has become familiar with, and Dr. Arash, and Dr. Malika, because we've been seeing it over the past few weeks in which we have been working on assisting GOTI. And we then had Nathan talk to us about the WHO Guidelines Review Committee, how it was established, and the processes of guideline development. Nathan also described different types of guidelines, including standard guidelines, emergency interim guidelines, and rapid advice guidelines. Nathan also focused on generating evidence for a guideline recommendation with systematic reviews of evidence, economic evaluation, and critical appraisal. He went through the guideline development process with its, there was this really nice diagram, and by the end of today you will all have a link to the presentations. So there's no need to be taking notes, but one of the important slides I think that was there was the guideline development process that Nathan described, starting from the scope of the guidelines to setting up the guideline panel and the external review group to formulating the questions and retrieval of evidence, assessment, synthesis, appraisal and certainty of the body of evidence, to formulating the recommendations and so on, dissemination, implementation and evaluation of impact. Describe the grade methodology a little bit. Dr. Arash then in his second presentation shared that only a few programs in countries of the region at least have this national perspective, and this is something that, that we should be very proud of, that there is Egypt is probably going to be a role model for many countries of the region in that it's the first to establish a national program for implementation of development and implementation of national guidelines. And this is actually, there was one of two key requests that came with the Regional Committee resolution in 2019 on evidence-informed policymaking, including the development and implementation of a regional action plan for evidence-informed policymaking. Dr. Arash also talked about the integrated multi-concept approach for the institutionalization of evidence-informed policymaking, and he talked a little bit about the national plan for guidelines. He talked a little bit about the timeline of guideline development, and we deleted the slide. This slide was the timeline. This was a bit of discussion because this is not very much consistent with what the plans of Dr. Muhammad and the team at Gothi is. We also talked about the cost of guideline development and various considerations for national action plans, like the stakeholders, the multiplicity and the multidisciplinarity of key stakeholders, setting priorities, the scoping, the time and resources needed, the human resources needed, the role of academic institutions, the attention to provincial concerns for implementation. We talked about priority setting, we talked about scoping. There is some priority setting that was already done by the General Organization for Teaching Hospitals and Institutes. But then Dr. Arash also expressed some of the important issues in priority setting. And he talked about scoping and the importance of scoping as a key part of the planning process in the clinical guidelines. He talked about how to scope a guideline and development of a first draft, to revision, to steps for developing the scope, to searching the literature, and so on. So today we are going to be focused on the experience in Egypt and other parts of the world, certainly in this region. And we're going to be hearing from Dr. Murad, some issues related to the gaps and the needs for establishing a functioning system for guideline development. We'll be hearing from Dr. Mehrez and Dr. Malika. We will be hearing about the challenges and opportunities in Egypt as we have assessed them in the past few days. And we'll be discussing the action plan for Egypt, the national action plan. So the first break today will be around 11:30. And it's during this time that I would invite you for the group photo. I don't know if Dr. Mohammed Fawzi is coming today, Marianne, do you know? Is Dr. Mohammed, he's not going to be coming? Okay, he said he might come sometime in the day. I was just trying to have him and WR at the same time. But anyway, Dr. Naima will be here around 11:30, around the break. And then we will have our lunch break at around 3. So there's a little bit of changes in the schedule, and I'll basically moving things up and down. We will start by Dr. Arash describing the attributes of good practice guidelines and appraisal tools. So Dr. Arash, if you can please join us here. Thank you so much.
Shukran, Dr. Rehan. Sabah al-Khair, good morning, colleagues. So, can I have the slide moving tool, please? Shukran. Okay, as Rehan mentioned, so today we have some discussions that are about the theories of work and how, experiences of others, we focus on those. But then the main purpose is that to focus also on national plan in Egypt. So while everybody is here, this is an excellent opportunity to become more detailed and go into that agenda. So we try to cover the things that are more related to this discussion by noon, by 12 o'clock, so that in the afternoon we would have more time to go through those. So I start by attributes of good guidelines, and that's the tool for appraisal. I know that's a very important question that you have in the country. So just introducing the most relevant tools that are happening. Okay, so first of all, I mean, I'm referring to this statement. This is relatively old. One of the reasons I like it is because it was one of the original reviews that showed the effect of guidelines. The other reason is personal. So this person here, Ian Russell, was my PhD supervisor, and he died recently. And so he was one of the pioneering people in these areas. So they actually showed it works. But then later work, it showed it only works if we do everything else also well. It's not just the guideline itself. So we are going to focus on that one. The big challenge is there are many guidelines, and many of those that are around are not good guidelines. For different reasons, including from the content, validity of recommendation, but also presentation, whether they are sort of answering the right question in the right way, etc. And when you have a guideline that is not really good, you're actually affecting the frontline staff. So I mean, the point is you spend energy, I mean, the country does a program to make the health system work better. If it doesn't help people who are on the front line, then that's not a good idea. So it's really, really important. Like the discussion we had yesterday, and you remember Nathan said that, I mean, the time we spent on the scope is not wasted because that actually results in a better guideline. So the planning phase, like the time we are not spending together for designing the national plan and sort of perfecting the national plan or making it optimal in Egypt. So that's the sort of work that should be done. Obviously, it's costly. We had many figures discussed. So one of the oldest work, and so last night I summarized this slide quite a lot. I'm just keeping the history, and then I jump into the current discussion. The oldest work was done in the US by Institute of Medicine there. They identified 8 attributes for a good guideline. So a guideline that is good should be valid in terms of content. So I mean, all of you have do research, you know what is meant by that. Should be reproducible in a way that, I mean, if other people come and do the same job, they probably get to something similar. We know that's not a perfect reproducibility because the membership of the panel is affected, but that's the aim. Be applicable to practice. It should be also flexible. It shouldn't make the sort of clinician jobs harder. It should allow them to be flexible within the things that are okay. Be clear, multidisciplinary process in terms of the sort of conduct of it, schedule reviews, and documentation. As you can see, I mean, most of these criteria are on the content, what is in it. Some are on the process and on presentation of the guidelines. As I will show you in a few minutes, the new tools, they're actually giving a lot of focus also on to presentation. So early on, the presentation was not considered that important, but then it has been realized if you don't do a good presentation of the guideline, you are not going to have it implemented. The other thing that you can see in this old definition, there is nothing about implementation. So it's actually more focused on the program itself rather than the target of the program. And again, that was lesson learned, that implementation cannot be left to others. So it's not like people saying that, well, I developed the policy, other people have to do it. It's that if you are developing the policy, you need to think of the people who are doing it and develop the policy in a way that people can do it. So I write a guideline to change behavior. It should be written in a way that people who want their behavior to be changed can do it, can improve. Okay, so a work I did several years ago, and so the final result published in 2008, we looked at the user's perspective. So this was not about guideline development. We actually went to clinicians, asked them, why are you following certain guidelines are not followed. And in terms of the questions we were asking, we actually gave them some of the best examples of the guidelines at the time in terms of evidence-based production, and said, why aren't you following this? Why aren't you using this guideline? If this guideline is evidence-based, yes, it's evidence-based, but. And those buts resulted in 7 criteria that actually helped. One is, first of all, it should be valid in terms of, I should trust the sort of the content. But then when you continue discussing with them, so it was a detailed study, they actually, because as a clinician, you don't have time to go and check the statements. But if I trust Dr. Murad and saying that this guideline has been signed by Dr. Murad, then I feel more comfortable. So the body that is behind the guideline, if it's a trustworthy body, that people can trust about the process, the sort of the credibility of that, then they are more likely to use the guideline. That's why, again, it's important to focus on how to do the program in terms of the sort of national level. The presentation itself, so if it's simple or not simple. So I mean, I know all of you are familiar with NICE guidelines. A very famous case is that NICE has now has had a national guideline for asthma for many years, for management of asthma. The first time NICE wanted to do asthma guideline, they started to work on it, and then they suddenly stopped. They said, well, the British Thoracic Society has already a guideline on asthma, and because of that, we are not going to produce asthma guideline because this guideline is still valid. This was quite a strange statement by NICE. They hadn't done it, and I don't think they've done it since for any other society-developed guideline. They did jointly develop some guideline with certain societies, but very rarely. And that British Thoracic Society guideline was not famous at the time to being based on the best available evidence. There was some concern that maybe it has been affected by some pharmaceutical companies at the time. So they were concerned about certain medicines being there, certain not being there. Why was it so popular that NICE couldn't issue the guideline at the same time as they releasing the guideline? They had done an excellent job on presentation of the guideline. They actually had used the guideline to make the management of asthma simple. So if you are a clinician, not a respiratory physician, that's your job. If you are an internist or a family physician, so asthma is not a simple thing to manage. It could be mild, it could be moderate, it could be severe. It's difficult to predict the course. You are worried that, I mean, if I go too much on treatment, the side effects might affect. If I go slow, there could be attacks. So there are, and don't think of the treatments you have now, because many of the things we use today, they didn't exist about 20 years ago in terms of the sort of, I mean, especially inhaled corticosteroid, etc. There were some, but I mean, that wasn't easy to apply. But what the BTS guideline had done, it had actually categorized asthma under 3 categories, and then giving a specific recommendation. In a way, asthma had become 3 diseases for a clinician. So you test these things. If the answer to these is yes, then it's a mild. Then you only had 3 things to think about. If it's moderate, do it like that. So the stepped approach they had done for the management of asthma guideline, and since then many other teams have done it, but they actually had done also more because their guideline was supported by pharmaceutical companies at the time. They had money for implementation. They actually trained many nurses in the UK at the time to know the guideline itself. So if you were a clinician, your nurses are also very well familiar with the guideline. So it's much easier to follow. So in a way, at the same time, there was another guideline on asthma produced by some of the best evidence-based thinkers of the time in the UK. They call it the North Yorkshire series of guidelines. One of the first one was on asthma, and that was not taken up at all. The evidence was more valid, but it wasn't user-friendly. It could not be easily used. So absolutely important to do the presentation properly. The other one is influential people. So so influential people are different things. So it goes, one is that what we call opinion leaders. So let's say in a certain area of work, there are 2, 3 clinicians, 10 clinicians, everybody knows. And we know in large countries like Egypt with sort of many academic institutions, it's usually that if you are a graduate of Ain Shams, your professors that you really trust are these and this. And if you are from Qasr al-Aini, if you are from Alex, but there are clear people in certain areas that if they change something, if they prescribe something. I remember I was talking to a clinician many years ago, and then about this discussion, and he said, well, that he was an endocrinologist, and he was referring to his guru. He said, when I started practicing, what I would do, I look at how he manages patients, and I would copy the way he would sort of prescribe, etc. I would trust him. And then we realized, so we started doing that in our clinic, and that was a referral clinic, And in about 2-3 years, we realized then people who are referred to us, they actually have exactly the same way that we've done. So then clinicians in the community, they had copied the same approach coming back. So if those influential people are identified, then you do a better job, and then you use that. That's one way. The other issue of influential people is actually people in charge of the case. So let's say I'm managing epilepsy. So as a community physician, especially if not, epilepsy is not my specialty, even if I refer the patient, usually I trust on someone else to check the process. So, I mean, so if a consultant in the hospital, if they don't accept a guideline, as the referring person, I cannot do anything in the primary care center because this is they will see the patient and they will say this is correct or not. I know in Egypt the referral system doesn't work the way we are discussing, but still if you rely on the consultation of others when the case becomes difficult, then those others, even if you do not consider them as your sort of opinion leaders, they will affect you because you know that the patient is going to talk to them as well or to another doctor, and then if that doctor doesn't accept what I've done, I'm in bad trouble because the patient come back saying that, well, I mean, the person, you know that the name so big as it is, even if it's from the guideline. So then it's really important to make sure these lines are seen. That's why national guidelines are always a good idea, especially when they are credible, because they solve all these barriers in terms of process. Yes, go.
A scientific committee or a committee to do the guideline for cardiology or something like that. So I have to put both the networker and the scientific together.
No. This is not about the guideline development group composition. This is about sort of so the point is there is always a balance. So obviously when you start to think of composition of guideline development group, as we mentioned, you should have different sort of stakeholders in it.
Guideline needs scientific people, good researchers, a full multidisciplinary team.
Yep.
But at the same time, what I catch that we have to put an influential person.
So people, yes. But the only thing you should be careful, that's practical. So there are influential people that if they say this is water, even if you add sort of, I don't know, sort of lemon into it, it's still water. They don't change their mind, never. So such people are not good for a guideline.
Yes.
So they should, for a guideline committee.
Yes,
even if they are really.
They are not scientific.
Yeah.
Most of the influential groups, or not most, but a large group of the influentials are networkers, but not scientific people.
Well, I mean that's the thing you should try.
I'm sorry for interruption. Sure. I may be afraid from them in certain circumstances, but on the national level. This is a question. Thank you.
No, I mean, that's the point. I mean, the point is sort of at the national level, the sort of the level of discussion, because then I'm not the only influential person there. So I'm the influential person in the cardiology, but there is someone else who's a nephrologist who's also influential. So if I say something really strongly, they might also say something really strongly. So then that becomes, sometimes it's even good if there are really gurus that, I mean, they have a point, it gives them the chance to actually test it against others and against the evidence. The other thing is that in terms of the process, what you should always do is that when someone becomes a member of a national guideline committee, they should tell you about the conflicts of interest, so those statements. But the other thing that they should tell you is that I'm ready for my ideas to be questioned. I realize that these are statements usually written. I realize that in the committee there might be evidence discussed that is contrary to my current practice. I should be able to discuss those openly and not be offended. So that's the sort of thing. But then if I mean sort of, on the other hand, as I said, it's not all about influential people. But this is beyond that. This is about when the guideline is out. You need to spend time to sort of you get, yes. And usually when you have a national body, it's not that important that Arash is there. The point is that whether the sort of Egyptian Society for for say, orthopedic surgeons is there or not. So in a way, it's not my name. It's actually the society name that is coming. So that becomes the sort of the power there. Organizational factors, we gave a lot of examples yesterday, so I'm not going to repeat that. And then the disease characteristics. So I mean, certain diseases are managed in one way. So in a way, the implementation plan, implementation thinking, and the guideline format, it very much depends on what disease is that. So asthma, as I said, relatively complex in terms of management. In our area of the world, is underdiagnosed, undertreated in generally. So, but then there could be, if you talk of secondary prevention of cardiovascular disease, it's relatively easy in terms of 1, 2, 3, 4, what to be done. So then you don't need to think of very complex issues. So in a way, you consider the concepts of disease that for which you are developing guidelines. And then lastly is that what the team does for dissemination. So I mean, that is not, doesn't need further information. Okay, now I jump to what is really important for Egypt today. So I agree to many of you are familiar with it. If you've looked at the sort of guideline development, it's a tool that has been around for, well, the previous version was Agree, so then the Agree 2 came in. I think it's at the 3rd edition of it at the moment, so it's been twice updated, but the updates are really small, not massive. I checked all the updates last night as well to just make sure where we are. So I just spend this time to go through it quickly, and I go through the items. I'm not going to explain them too much. If any of the items you don't understand what it meant, please ask. And if anything you are not sure, be sure that there is someone else also in the room who doesn't know. So don't think that's only for me. When you ask a question, it's good for everyone. So let's do that. So the domain, Agree is now under 6 domains. As you can see, for example, applicability is one clear domain. You remember that early versions of these two such approaches didn't have enough attention to that. Clarity and presentation, and then obviously the editorial independence, so being away from conflicts of interest, etc. Okay, 6 domains. Overall, there are sort of 23 questions that you need to answer. For each question, there is a 7-point Likert issues. Usually, if we use Agree to assess a guideline, so 4 people, it's recommended to do the assessment independently. They mark, and then those marks are calculated and then discussed. But then it's also about why you mark high and low. So there are certain rules. I mean, that's beyond today, but I mean, inshallah, in the technical workshop we specify one session, and we practice together how to apply Agree and how to take it forward. So those domains, as I mentioned, so the numbers in the bracket is the number of items in each domain. So I mean, the first 2 each have got 3 domains. Rigor of development, that's about the content, 8 items, sorry. And the clarity, 3 items, applicability, 4 items, and then editorial independence 2. And then in the end, it's also, you do all of that, but there are also 2 additional questions. Is that, well, having read all the, sort of answered all the 23 questions, overall, what do you think? Is it a good thing or not? So it doesn't just do the adds up. It actually asks you directly, what's your impression of it? And then, do you think the guideline, whether it's good or not, is something that can you really help your country, your setting, your context? Is it going to be useful? So these are the questions that are asked. So now, as I said, I go quickly through those. So the first domain is about the scope. And so maybe my back has been this, so I do this now. So apologies, colleagues, just to balance it. Scope and purpose here. So the first item is that the objectives of the guideline is described specifically. You remember the discussion we had yesterday about PICO question, the scope. So if that's done well, then obviously this answer is that it's done well. The health questions, so it says health. The earlier versions were about clinical. The reason it says health is that because Agree is applies to public health guidelines as well. So that's coverage is for both. Covered by the guideline specifically described. So that's the PICO questions and similar. The population, whether it's patient, public, etc., specifically described. I think these are very clear. Then a stakeholder involvement. That's absolutely important, especially in this our part of the world, that when usually people like to work with their people that they are close with, rather than so interdisciplinary work. So the guideline development group includes individuals from all relevant professional groups. That's absolutely important. You remember, all relevant professional groups are every professional group that is involved in implementation of the guideline. not the one that only orders it. Anyone who provides advice for it, for example, or is part of the interpretation of it, that's considered in terms of that process. The views and preferences of the target group. So different guidelines do this different programs. One is that sometimes you have a patient representative in your GDG. In certain countries, that's compulsory, to have 1 or 2 patient representatives. And I've been in committees when there was a patient representative. And when I became a member of those committees, my thing was that what would be the benefit of a patient there? So I mean, it's a good idea politically, but probably doesn't add much. That was my feeling. But when the guideline was being developed and the discussion of recommendations started, I really saw it, observed it, how important it was. So they would actually, the patient would tell you things that everybody was taken by surprise, saying that, well, seriously? The patient was saying that how this treatment was so bad and so annoying for me, and I hated it. I didn't want to follow it. And then everybody said, okay, let's look at the evidence again. If that one of the options is so unacceptable to the patient, then maybe if there is something also equivalent, we don't recommend that one. We recommend something else. So it helps. In other contexts is that you may not have a member, but then you can consult. You conduct sort of surveys, you conduct sort of interviews, or look at the evidence of interviews that other people have done by patients, etc. Yes?
Yes. Our medical syndicate can come as on behalf of our patients or not, as a representative?
No. Medical syndicate is not.
Not.
Patient representative, yeah.
But she is, I mean, one of its goals is to protect relationship between.
I know, that's true. But then it's a medical syndicate, so it's not. I mean, there are patient groups that might come, but then the patient groups, you need to be careful as well. So the good thing is I don't know about the patient organizations in Egypt, anything, so I can talk sort of
that's
freely.
what I mean. We don't have a real
certain patient organization group that are funded by pharmaceutical companies at the same time. So then they become the promoters of one treatment over the other. So that you should be careful. But so the patient should be, but sometimes, you could have a sort of a very educated patient. I mean versed into the situation. So let's say sometimes you know someone that has been advocate for a case in the country, or in one of your wards, there was a patient that has been chronically affected by a disease. Yes. And then you may propose those names, the committee decides which one is better, and then you add them to the process. And the target users are clearly defined for whom to apply. So that was part of the scope we discussed yesterday. Rigor of development, systematic methods are used. Remember Nathan's discussion, those are methodologies. That's really important, and we will cover them further later. Criteria, not today, in future events. Criteria for selecting evidence. So these are methods, main elements of a systematic review of evidence. So what you should do. The strength limitation of the body of evidence is clearly described. The methods for formulating the recommendations are clearly described. So when the study says drug A is better than drug B, it doesn't necessarily always give you the text of recommendation. The text of recommendation is an art, how to write it, and also a decision. So it's, especially when the evidence becomes a little sort of not clear cut, which is most of the time, then it's really important to describe how you define the question, who drafted the question, how the committee made the decision whether it's okay or not. So those methods that have been used is important to define. The health benefits, side effects are considered. It's not just that we look at the effect, we actually look at also the side effects as well. There is explicit link between recommendation and evidence. So it's not that, well, we read 100 studies and this is our recommendation. And then you say, well, the 100 studies were saying something else. How come this is the recommendation? Oh, the committee decided this way. So then there is no explicit link. So then this is not a good job, basically. The guideline has been externally reviewed, so that you send it for review to others. Early on, many years ago, people were asking the guideline to be tested on the ground before being approved. From a start, it was clear it's not possible. The main reason it's not possible is that the guideline takes time to develop. And then testing it also takes a lot of time. By the time you finish the testing, you need a new guideline, basically. So you cannot rely on testing. But external review is always a good thing to do. people who are not part of the development, but they have views and they can read it. And then there is a plan for updating it. The fourth domain is clarity and presentation of it. So the recommendations are specific, unambiguous. Well, I mean, if we don't have, I don't know whether do we have epidemiologists in the group or not. So when they say, for example, that the title of a table should be very clear, the title of the table should tell you everything. This is about the recommendation as well. When I read the recommendation, I should understand what it says, without even reading the rest of the document. The recommendation itself should be sort of clear for action. And it should also, if asking to do this, you should say, do it. If it says don't do it, you should say, don't do it. It should not be, well, we think this is better than the other. That's not a guideline recommendation. That's a research finding. You should be specific. And if you are in doubt, say, I am in doubt. We are not sure which one is better. Select one of these two. So be clear. Don't leave anything in for the interpretation of the users. And also, it's easy to find. You remember yesterday we were talking about guidelines that you should go through pages and pages and pages to get to the recommendation. That should not be the case. Applicability. The guideline describes barriers and facilitators of implementation. So you think about yourself and others who are going to receive the guideline and going to use it. What would be the barrier? Provides advice and tools on how to put it in practice. So you may develop sort of a protocol for it, a Gantt chart, a flow chart, algorithm for action. So those things, and the guideline development group, if they plan it well, they are the best people to do it. Don't think, well, other people do that. No one has spent so much time on it than you as the guideline development. So then do it. In certain guideline programs, they actually start working on the algorithm from the start, even before they finalize the recommendation. A couple of members, they start thinking of the processes because it takes time to complete your thinking, and when you have recommendation, you just put the recommendation into the algorithm. So the resource implications, how much money is needed, if new staff is needed or not, are also considered. And then there are monitoring and auditing criteria. This is not always possible, but it's best to try. If there is an indicator you can suggest for assessing, then you help also the managers, the policymakers to see whether the guideline being followed or not, and sort of by recommending audit criteria. And lastly, editorial independence, views of the funding body, because guideline needs money. Whoever who is giving money to the guideline, the views of the funder should not be determining the results. So that's important to make sure. So certain guidelines, for example, they said the budget was provided by the insurance organization for development of the guideline. However, the members of the insurance organization were not present in the discussion when we finalized the recommendation. They had no role to approving the text of the recommendation. So you make sure there is independence between the person who paid the money and sort of the process. And this adds a lot to the trust, the sort of reliability of the guideline. Especially, I would say as a national body, never involve pharmaceutical companies in guideline development. So that's a sort of very clear cut. Because then you are, even if they are not affecting anything, don't use their money, don't involve them. Even if they are not affecting you, people outside, well, they don't believe you. You lose the credibility because of that sort of conflict of interest assumption. Did I cover it? Yeah. Everything? Sorry. And yes, the competing interests of the development group have been recorded. We discussed that yesterday, so we are not repeating again. So these are absolutely important to highlight. Then there is for each one of them, there is a question, do you agree or not? And then there is a text, I haven't put it here, you explain why. Because everyone does it independently, so then you put your reasons down, and then you discuss that if everybody was saying 7 or 6, then you say fine. You don't need discussion. But if someone says 7, the other one said 2, then you need to discuss with each other why I'm 7, why 2. Then because something you might have seen, I haven't seen, and then you discuss and sort of get to the final point, and then you do calculations. So I'm not going through those details. And then they are standard, so that's fine. Everything is actually well described there. And then the overall assessment. So you've done all of that. So now tell me, what is your conclusion? With having read the guidelines so carefully, having assessed it so carefully, overall, I still think that's a good thing to do? And do you think it's going to be used in practice? Okay, thank you. If any questions, so what is the next session according to the agenda?
The examples of national.
Oh, so it's me again talking.
Yes. No, today we will have you.
Sorry?
Sit down for a minute.
So, no, standing is fun, but if people ask questions, that gives me a reaction. Okay, so there are questions. So, well, there are 4 questions. So where is the microphone? So if you can, maybe, so we start from here. Can you pass on the mic, please?
Regarding a great tool, I'd like to ask about the scale. Every point has to be pointed like from 1 to 7, and at the least we get the summation of the 32 points. My question is about the final number, the interpretation of number. If I find the total is above 70, below 70, what's the meaning of the summation of this number?
I mean, well, the rules of thumb is that so the bigger the number, because you have a total. So let's say 23 questions, each question 7. So 7 times 23 is the maximum number you can get. So the maximum number, because then if you are 4 people, you divide it by 4, and then you standardize within domains. So I mean, the tool explains it really well. So it's nothing complex there. You just do it. That's it. But then the proportion of the score that you get, so the higher it is, you feel more comfortable. So that's the general rule. But for me, in practice that I've used, agree with many groups over the previous years. I haven't applied it in recent years, but I mean, I've done it a lot in the past. The overall assessment is really, really helpful. So the scores help you, but then you sum it up later on in the end. The other thing is that because you do the sum up under each score, you don't do a total sum up under each domain. Then if, for example, the presentation is bad, the content is really good, then you say, okay, so maybe we can use the sort of the evidence behind it, adapt the recommendation, but we really need to work on how to design it in our adaptation for the national context. No, it would help. Apply it 2-3 times. It's like a sort of, we have a joke in my country. Someone goes and buys a mobile phone, and the person says, well, I mean, I want a mobile phone with a round number. I want a SIM card with a round number. And the person said, yeah, okay. I have a round one, so I'll give it to you. Very happy. And then he looks at the number and says, well, let's say 01275478910. Says, that's not a round number. He says, no, say it a few times, and then it becomes round. So if you repeat it, so then it's round. So the same applies. So it looks complex, do it a few times, you feel comfortable. It actually helps. It very well helps. So especially because it's not just about marking, it's actually putting down the reasons for your mark. And those are the things that would make it clear why you are going to use it or not. So I think you wanted to say, okay, we have this table. Shukran.
Thank you. First of all, thank you, Dr. Ashar, for this great informative session about this important topic. I have, as the topic is very important, I have a complex question. First of all, what is the qualifications needed for a panel to evaluate a guideline? Is it needed to be a clinician, an expert in the specialty, or a multidisciplinary team? This is first of all. The second is agree to requiring evaluation upon the domains we mentioned. So these domains should be mentioned in the guideline. What if these domains are not clear or mentioned and in the guideline? And actually, the first question is we are testing the credibility of the guideline, and we have to see the impact of many pharmaceutical companies and whatever. The members of the formulating team would be at the same time representatives of scientific societies, at the same time maybe representatives of universities, and key opinion leaders, and at the same time they are clinicians. So what is mentioned in the guideline would be one trait, one character. Say a member of this scientific society or this university. This would make a bias in my evaluation to this guideline, as I think. How can I deeply investigate the other traits, or should it be written in the guideline? Thank you so much.
Yep, I mean, the answer to the second question is actually, as you summarized, it should be written. It should not be only one affiliation. You actually, you have to report every affiliation you have. I mean, the way that I'm not saying that Egypt, you do it that way, but in some of the European countries, when they ask you a question, they ask you even about your husband, your wife, your kids, your brother, sister. If anyone in the close relatives has something in pharmaceutical company, you have to report it. If one of your students have received a grant, if you bought a sort of a tool in your ward, you report everything. But so in a way, those becomes more of a clarity issue. It doesn't mean everyone who said yes to any question would be disqualified, because we know that the range is different, and we know also the funding sources for the clinical work on academia is quite varied, and it's not that surprising that there is some funding coming. But then the issue becomes, you make it very clear, and then the committee decides. I mean, if this level of engagement, well, that's a conflict of interest. Even they ask you whether you've been to any court testifying for a case related to this medicine before or not. I mean, so to that level, they go to detail. But no, it's not about one affiliation. It actually should have. If you don't see that, then obviously you reduce and mark here. In terms of qualifications of people who do that, as you noted, so I mean that you also mentioned it very well. The point is, so some of these questions you really need, if you want to see whether the methodology is correct, especially the reader. Well, you need to know the methodology, otherwise you cannot. On the other hand, it's asked whether it's something that is going to be applicable on practice. So you need to know practice. Ideally, it should be people who know both. They don't need to be the best person, not at all. It does work with average knowledge of those elements. Average knowledge, I mean, you know the methodology and you are practicing. If you don't have people with both, then combine them. Have people who know methodology, have people who know clinical background, and then together they do together. And the questions about presentation, etc., actually trust more by people who don't know the area, because they are better people to say whether the presentation is good or not. Because if you know it, you find your thing in it because you know it. The person who doesn't know it is the better person to say, well, is it a good presentation or not? Because they get it from the presentation directly. Madam?
I would like to join my colleague in thanking you for such an informative presentation. I have two questions. My first question is about the attributes of good practice guidelines. Now you mentioned applicability, clinical flexibility. Does that mean that the guidelines should be tested by experts or peers or something like that? The second point is about scheduled review. What is the recommended time frame for reviewing and updating the clinical practice guidelines? Now the second question is about auditing. I'm so much interested in clinical audits and auditing the process of application of clinical practice guidelines, how they are followed, when they are followed. So you mentioned that the guideline could contain auditing criteria or monitoring criteria. Is that a mandate? That's the first point. The second point, if it doesn't contain such criteria, can I choose as a clinical auditor, can I choose certain criteria from the body of the clinical practice guideline? And is there any recommendation which sections should I choose? For example, should I choose the classic steps that are followed, or should I choose a critical step, or should I choose an outcome, or should I choose a diagnostic workup? Please enlighten us in this aspect. Thank you.
Okay, I mean, so you asked very good questions, and answering them in detail needs a lot of focus. And many of them, you know, they pointed how to apply them in practice. So remind me if any question I missed.
The first question is about attributes of good.
Yeah. So flexibility is a judgment. Is not sort of a very clear cut. As you can see in the new one, the one that we are recommending, it doesn't refer to it. That directly says whether it's applicable. So it's become part of the applicability. The point is about, it should not be that rigid that as a clinician you cannot apply it. So let's say if the guideline is about sort of focus, the main body of evidence is coming from uncomplicated cases. And then, so as a clinician, I have comorbidity. So then it should not be in a language that I become worried how to manage the comorbid cases. So in a way, so it's a judgment. So the clinician would say, but not every flexibility is correct. So that's, remember, a guideline that is so flexible that I can do whatever I want to do, then you don't need it. So then why did you spend your time develop the guideline? So that's the balance. I mean, as I said, when the guideline has a position, you should do this very clearly. So I mean, actually some guideline program, they develop a list of verbs. So saying that in your recommendation, you are only allowed to use one of these verbs, so that to reduce ambiguity. And then they define it, if it's used like this, so it's wajib, yeah, I mean, whatever, I mean, sort of the language. So the next question quickly, the title, if you give.
It's about auditing criteria or monitoring
okay.
criteria.
So that's, I mean, you said, first of all, I mean, this is one item among 23 items. So not every guideline has done it. I know it's not that easy. Yeah. If you do a guideline, a national guideline, spend time doing it. Developing good monitoring criteria requires expertise. You need to know measurement methodology. So I mean, it's not every clinician is the best person to give you the best audit criteria. So you might need a methodology to spend time, etc. There are some rules of thumb. Use the least number of criteria that covers the main areas of work. You do not need to measure everything. Think of what are the main things that apply. Then that's sort of, and then I'll also think of the things that measuring them does not require a lot of work, new data collection. So think of what exists in the data system. So that's why, for example, information specialists can help quite a lot in such a process. So then develop it. Yes, if it's a good guideline, doesn't have audit criteria, absolutely, spend time on it. Yes, if in the national program of guideline, you actually do that. Maybe in Egypt, you will decide that actually the clinical governance team are the ones that are going to develop audit criteria. So you become part of the national agenda, but you reduce the burden from the guideline development team. The agreement becomes, when they finish the recommendation, the clinical governance team suggests some audit criteria, they review it and say whether that's okay or not, then it becomes the national criteria for auditing. So any combination is okay. The most important thing is to make sure there is.
Yeah, I was asking because the General Authority for Healthcare Accreditation and Regulation, GAHAR, in its latest edition in the Hospital Accreditation Standards 2021, has put a standard for clinical practice guidelines following and clinical care standards. So maybe when we have the national clinical practice guidelines, we can choose the clinical care standards, and which includes some indicators of performance, and then the problem is solved, actually.
Yeah, absolutely. And also, the only thing I would say, it should not be overdone. The last thing you want is that your clinicians are filling forms rather than seeing patients. That's some of the quality of care programs, that's their side effect. So it should not become like that. But the things that are essential. Madam? So just maybe use the microphone, please.
I have been asking maybe some of the previous questions about, you mentioned that guidelines need to be revised by external personnel. You mean an external personnel not involved in writing or in applying this, but practicing the subject itself, or writing and appraisal and such issues? Another question, this is the first question. The second question, overall assessment. There had been a discussion that I will take out of it. Maybe I can prevent implementation of this guideline if I have a very low score to that extent, or maybe I will revise it and re-practice issues on it to implement it in the next yearly update of this guideline. It needs to be every 2 years, or when to be applied. Thank you.
Okay, so for external review, I mean, I would say it's, the best scenario is that you select a combination of experts and the users. I mean, experts, I mean the people who are well-known, having knowledge in the area, because they might see things that other people cannot see. I mean, and the committee might have been 2 bogged down, focus on certain things. They might have missed important issues, so that's important. And also people who are applying different aspects. So, but in a way, external review is, you judge it better. Again, in guideline programs, it's always good idea to select who will be your external review. One way to do that is that, let's say, there are 10 physician societies that are relevant to the topic. You can members of the physician society, 4 of them as members of the committee, the others are from other stakeholders. Then you know that for external review, you definitely involve those 6, so that they also. So that's sort of policies you do. In terms of using Agree To, well, why do we need the tool? 2 elements are there. One is that as a national program for adaptation, I go to adaptation quickly, the first thing you do is that you find a guideline, and then you want to decide to adapt it. So you use Agree To see whether it's a good enough one to adapt. So that's the first use, when you want to bring something as part of your adaptation program. It gives you 2 issues. It doesn't just tell you whether it's a good one for adaptation or not. It will actually also help you to identify how to adapt it. What should be your focus? Especially the point of whether it answers all your PICO questions, because you do that after your scope. You have the scope and then you go for that. The second case is that this is a decision that the ministry should make. And there are different scenarios. Certain programs, the national agenda is always initiator. The other programs exist. I don't recommend it as a national program. What is possible is that the special societies themselves, they develop guidelines, okay? Then they ask Ministry of Health, please approve our guideline. And you say, well, I don't know. No, the best clinicians sat together. We followed all the great methodology. It's excellent. The point is, what would be your criteria for approval? Then you use an appraisal tool like Agree, and if they fail in the Agree, then you say, khalas. I mean, this becomes one of your tools to appraise something that the others have done. So, I mean, if you decide to do that, if you decide a line for adopting guidelines that have not been developed as part of the national program, but has been done by other national bodies in the country. So if you want to do that, that's also. These are your 2 applications, basically. So, and then you do that, yes.
Could we utilize the real-world practice to adapt our guideline instead of inviting the people who manage? Because there is a lot of differences in practicing. The guideline is something, and the practicing is something else. Usually, you.
Can you give examples? Because
like till now, worldwide, beta blocker is the most common used antihypertensive drug. Despite of that, the guideline ESC and the American guideline downgrade the use of beta blocker. But because the beta blocker is already had approval in the insurance and widespread between the community and even convenient to the patient because it is cheap, it is effective, and many things, still now there is practicing prescription of the beta blocker in the management of hypertension as the first line in most of the countries, not only in Egypt. Despite of that, there is a difference in the guideline. It is downgraded. It is just in compelling indication with ischemia. So we can use the real world actually practicing this, and it doesn't bring harm. Actually, there is a other drug which carrying more benefit, but it doesn't provide a harm for this population. So how can we use it without damage our guideline?
I actually turn the question. The point is, how are you sure that the practice is actually a good thing to do? So that's the question I ask. I'm not saying that the guideline recommendation is the best advice for the society. But as a national committee, what you do is you actually look at the evidence behind that recommendation that downgraded the beta blocker. You see the context, you bring the sort of assessment, and then you decide. So the way you do it is that you say, well, this is commonly being used in Egypt. So then obviously that's a question. That's a question for you to address in your guideline. The way you address it is not that you accept or reject that practice. You look at evidence. You analyze the evidence, you look at the old meta-analysis that have been conducted. The good thing about hypertension is that There are so many even grade tables that you can just copy, and you can get not only the systematic review, you can actually also get the grade table. You can see what has been the implications, how the committees decided, the details of that. You put that in front of you, look at the latest studies, look at the data from your own country, you bring all of that together if you need to adjust, and then you make a recommendation. So in a way, your purpose is to guide your clinicians. So then obviously you should make a recommendation that makes it clear. So then if you have done that, and then you say, I'm sorry, I don't want to say something that is wrong in terms of evidence. So, and I'm not updated at all on this at the moment. But the point is, if you end up saying, you find out that this should not be the first line, then you put it black and white. Do not use this as first-line treatment for hypertension. That's it. Even if everybody is doing that. So then that's your role. That's the added value you bring to your health system. But then if you realize, well, it could be actually one of the two options, then you allow it to continue. So in the guideline recommendation. And then the rest becomes the implementation plan. OK, let's go to the next talk. And I promise that this one I go very quickly. The main reason of this one is that this presentation is that because you asked for it, I heard from several colleagues they really wanted to have examples. The second thing is that to tell you the things that are called perfect examples do not exist many. So in a way, it's to make sure you select the best options and try to do it really good. Because it's one thing to have something written nicely, it's the other thing to make sure the nice things are done nicely as well, so they are implemented in practice. Okay, first of all, this is an old photo, 1998. I don't want to say something politically wrong, but many of you were very young, very, very, very young, so at that time. So this is a clinician, a physician in the UK. This is the 855 guidelines that he had received. And he had put them on the pile and he sent this as a letter to the BMJ. BMJ published it with the photo. So that how am I supposed? And this was before the NICE agenda starts in the UK. So many guidelines. The case of many guidelines still is the case. And it's happening everywhere. Especially in countries who do not have a national agenda, but they have accreditation program. Because accreditation programs ask about guidelines, then you end up every hospital starting producing guidelines. And then becomes a big situation. So there are issues of local setting, conflict of interest, different bodies, technical capacity issues, methodological limitations. So the national guideline program around the world started from early 80s. International organizations, several of them are involved, depending. We did a study several years ago. We updated it 2 years ago in terms of what change has been made. But this is from the published paper